Hello, and welcome again to the Surgical Clinics podcast. Surgical Clinics is a bi-monthly publication consisting of review articles devoted to a central topic important to general surgeons. Surgical Clinics has published for over 100 years, and the series and the podcast can be found at www.surgical.theclinics.com. I'm John Vasallo, the managing editor of the series here at Elsevier, and for our 12th podcast, we will focus on the April 2024 issue on trauma across the continuum. While the principles of trauma care have remained much the same over the years, advances in pre-hospital interventions, transfusion medicine, hemorrhage control, and minimally invasive surgical techniques have shaped the specifics of how patients are cared for today. Here to discuss 4 articles from the issue will be our consulting editor of Surgical Clinics, Dr. Ron Martin, senior surgeon from the Department of General Surgery at Pullman Regional Hospital and Clinic Network in Pullman, Washington. Joining him will be the guest editor of the trauma issue, Dr. Marcy Feynman, Vice Chairperson and Division Chief of Acute Care Surgery at Sinai Hospital in Baltimore, Maryland. Welcome to both of you, and over to you, Dr. Martin.
Thanks, John. And Marcy, thank you so much for joining us today, and thanks to you and all your other contributors for a really outstanding issue on trauma care. Every time we come back to this topic, and we know over the 20 some odd years I've been doing this, there's always something new to go over and learn. It's a field that never sits still. Today we're going to start out, we're going to cover 4 chapters from this for the listeners. And as you know, we talked about earlier, it'll be pretty conversational the way we usually do these. But we're going to start out with a chapter on resuscitative care in the trauma bay by Doctors Van Gant, Clements, and Cotton. And you know, this is a topic near and dear to my heart, having spent a lot of time deployed with the military overseas, and certainly we have a long history in sort of the origination of blood banks and how to use blood. And it's in some ways has led the ways, not always, but it kind of has. But you know, just give us your overview. I mean, there's been an evolution from whole blood to crystalloid to products to whole blood again, all for good reasons. But you know, just sort of give us your 30,000-foot view on where we stand in the basic resuscitative effort.
I also love this one. I think that Brian Cotton, who is the senior author, is like a national and beyond expert in this topic. So we were lucky to have him write and contribute to this. But you're right, whole blood was the standard years and years and years ago. And then, you know, we switched to fractionated blood products for a lot of really good reasons. They go farther. We can do some targeted therapies for different patient populations. They were easier to store. They could last longer depending on the product. And those were all great reasons. And when that happened, we were mostly resuscitating patients with crystalloid anyway, because it was cheap and easy, but realized that our mortality and morbidity rates were really high, and tried to see what we could do better. So there were 2, major studies, the PROPER and the PROMIT trials, that looked at trying to do balanced resuscitation again, right? Giving people back what they lose. And for trauma patients, what they're losing is blood. So we've started by focusing on what we call 1-to-1-to-1 resuscitation. So you want to keep your amounts of packed cells, platelets, and plasma pretty even. And we can do that with component therapy, and people's massive transfusion protocols are mostly based around this, around keeping those blood products even. But in looking at the mortality benefits of 1-to-1-to-1 resuscitation, it's gone a little bit further to say, well, if we're trying to mimic whole blood, why not just use whole blood again? And so whole bloods come back into vogue, and a lot of the big level 1 trauma centers have whole blood programs at this point, and that's their go-to for resuscitation in the trauma bay. And it's important to mention that we're talking like immediate acute resuscitation in the trauma bay, because things do change downstream in resuscitations. But for the trauma bay, it seems like whole blood's the way to go. The hematocrit is higher, the platelet count is higher, there's more factor than in your component therapy anyway. And we're essentially giving people back what they lose. So, this has had such positive effects on our civilian population. Now, I think the military has always known this. It's a little bit harder in our civilian world, but it's gone so far that it's getting adopted by EMS to start pre-hospital also. So I think that it's borne out in the literature that whole blood is now the way to go for resuscitation for trauma patients.
Yeah, in the right setting, I'd say. I mean, one of my junior partners used to ask me how I remembered as much surgical history as I did, and I had to remind her that when I learned it, it was current events, because it's the one advantage of getting old. But some of our younger listeners may not really remember that a lot of this resuscitative strategy stuff came out of not really understanding renal physiology and the whole crystalloid thing. And if you grew up around Boston like I did and trained there the way I did, you had to know every single molecule of the arguments between guys like G. Tom Shires and Franny Moore and read the books about the Salt and Water Boys, or you'd be flogged by some senior professor at some conference. So, there were reasons why we went through these various maneuvers, and having been densely involved with the military's reintegration into whole blood and walking blood banks, by the time we got to the second Gulf War, we had a lot better capability for pre-screening the population for viral diseases that we didn't have before that. And, there are some of us that are old enough to remember non-A, non-B hepatitis. We don't talk about that anymore, but we couldn't test the blood supply very well. But you had a captive audience on a forward operating base or some other such platform to get whole blood for whenever you needed it, and they were walking storage containers. So, I mean, like everything else, a change here and a change there changes it back. I think smaller hospitals are still going to have a whole time. I mean, the storage capacity issues for whole blood and what it takes to monitor them and use them is probably going to work well at trauma centers that have enough volume to use it quickly. I'm not sure in places where it's going to sit on the shelf for very long is going to work out as well, at least initially. Maybe, you never know. But when I used to go around talking about, in the early days of the second set of Gulf Wars operation, everybody wanted to hear about it. Then after a while, all they wanted to hear about was how you could save money in austere environments. They changed their tune, but whole, when we talk about it, whole blood was magic. And for those who've had the opportunity to use it, it really does work visibly better in real time than anything else you can put together. But I think, part of what you said, if you look at massive transfusion protocols, there's another whole area to sort of dive into is what does it really mean and what does it mean to use it and why should you? So, what do you use for predictions, modeling, decisions about who you think is going to fall into the massive or ultra massive transfusion protocol?
I think a lot of people still fall on Gestalt, even though that's been proven over and over again to not be super predictive. Thankfully, prediction models do exist should we incorporate them. I think the ABC score is one of the more popular and common ones. This came into existence in 2009, essentially to provide a standardized assessment of patients who require massive transfusion. It's four pretty easy to measure parameters, and each are equally weighted at 1 point. So they include systolic blood pressure less than or equal to 90, a heart rate equal or above 120 beats per minute, penetrating mechanism of injury, and then a positive abdominal fast. Now, some people will argue that fast is very operator dependent. They'd be correct. And what if you don't have a fast? Those are all kind of reasonable things to consider. However, the cutoff for massive transfusion for the ABC score is usually above 2. So even without the fast, you can still use this a bit as a guide. And because of that, again, pre-hospital a little bit is starting to adopt ABC scores, because even though they don't have ultrasound yet, although I do think it's coming down the pike, not part of this podcast or discussion, but I do think that's going to be a thing in the future.
We could at some point could discuss whether that's a good thing or a bad thing, but I'm not sure, but I'm with you. Carry on.
But you can still use it, right? Because people who are
Sure.
sick from their trauma or blood loss are going to probably have at least the other two, the heart rate and blood pressure, and then throw in their penetrating mechanism of injury, and your guide's pretty good. Um, so that's one. Some people just use the shock index, and we've actually incorporated the shock index into our leveling system where I am. So deciding if patients should be activated as a level 1 or trauma delta or whatever it is your institution calls your worst traumas that activate your trauma team. Our newest guidelines have incorporated shock index into that too, because the chance of someone being sick and needing resuscitation and potentially blood and massive transfusion is higher. So again, this is just dividing the heart rate by the systolic blood pressure, and a cutoff of more than or equal to 1 predicts the need for massive transfusion with about 67% sensitivity and 81% specificity. Is it the best ever? No, but is it something to use that might be a little bit more accurate than Gestalt? Yeah. So I think those two are the easiest to incorporate.
Yeah, I'm with you on that. I also think that it's hard to fault a system that has you be slightly over prepared compared to being very much underprepared.
Very true. And at least in us, like in Maryland, our state guidelines, when we audit our trauma program, we can have an over triage rate of up to 50%, and that's fine. But we want our under triage rate to be less than like 5%. So,
And that just makes sense. I mean, maybe not to every administrator, everybody who has to like fund the program, but having been on both sides, I think it's an easy thing to make an argument for anyone that you can always pull back resources, and it isn't like you lose things by being ready to give them necessarily. I mean, certainly things you thaw out, you can make an argument, but other than that, um, but I think, one of the things I'd be interested in you discussing with us is people are generally pretty good at starting a massive transfusion protocol. I don't think they're necessarily as good as knowing when to like put the brakes back on or realize when they've resuscitated enough or how to fine tune it. So
you are very correct about that. And even because of that, in our like EMR, every time you log in to the patient, there's this big thing that pops up that says, this patient still has massive transfusion order. Do you still need it? That's like a reminder, because you also don't want to waste the products. Even if they're sent, you can return as long as they don't get lost and you remember to do that in a timely fashion. But yeah, I mean, eventually we have to transition from this kind of throw the kitchen sink at the patient to something a little bit more targeted. We do that a couple ways. Physiology obviously is the easiest one. Or if a patient is, um, I these patients that need massive transfusion probably need an operation as well, or at least some kind of intervention. It may be IR embolization, it might be an operation, whatever. So I think you're either going by, you know, physiology and hemodynamic stability, or you're going by bleeding is controlled, right? So when you get control in the operating room, or you get controlled with IR embolization, whatever it is, the mechanism that you need, once that bleeding is controlled and you get out of the intervention suite wherever you are, I think it's probably time to switch to something a little bit more targeted. And if we go into targeted resuscitation, hopefully, we'll talk a little bit about TEG and what that does for us these days. And
well, let's do that because I agree that if you just use the initial formulas that you have for triggering your predictive model, at a certain point you get the heart rate below the systolic blood pressure, and you do the anti-penetrating work by closing the holes. And so now you've taken away their mechanism and you've taken away their other features. In my experience, people forget to keep reevaluating that in real time. Occasionally, if you're in a big center all the time and you've got good people above the anesthesia barrier who are generally responsible for the transfusions, I think it works out better. But when you do get to a point where, as you say, the kitchen sink's been thrown at, you want to start fine tuning that. And for that, we get to viscoelastic testing or whatever the model. So what do you use to determine which products are missing, how you want to tailor your therapy?
Where I am right now, we use the TEG 6. We actually got it on a trauma grant a couple years ago. And so, we send standard labs also because people feel obligated to send their coags and their fibrinogen levels and all their normal standard labs. But we also run tags on all these patients. We try and run them immediately from the trauma bay, but we don't use it upfront to guide anything, right? They're fast, but even the 10 to 15 minutes that it takes, you could have given the patient 20 units of blood in that time through a Belmont or a massive transfusion or whatever. So, to me, this is much more helpful for like the later now targeted resuscitation. And it'll help us decide if, are we clotting okay or not? Do we need platelets? Do we need factor at this point? Do we need more TXA? I know we didn't talk about that initially, right? But TXA, at least for us, is part of our massive transfusion protocol. Like once we activate it, it's TXA.
In my experience, people frequently learn to drive by bouncing off the opposite guardrails. And we've gone back and forth with TXA at least a half a dozen times in my tenure with the military and our clinical practice guidelines and sort of what we've got out of ISR and Surgeon General's office and stuff. But so you're a TXA adherent now. Are you a single dose or multiple dose, and what's your time cutoffs?
So I'll say that we're kind of TXA adherent because our current guideline that were written a few years ago has us as 1 gram upfront of TXA, and we are in the process of changing our loading dose or whatever to 2 grams at least, because now the current literature is more TXA early on is better. um, so we were adherent when it was 1 gram was recommended, and now we're changing our things to 2 grams. We're also looking into, the diamond of death instead of the lethal triad and incorporating calcium for hypocalcemia and stuff, but I don't think there's a downside to calcium. But I digress.
But where are you within? Are you playing within the 3 hour cutoff, or because that's another function? And when I lived it back east, every trauma got to us quickly.
Right, that's what I was going to say. I'm in Baltimore City. My transport time is like out from my front door. So it's it's fast. So the 3 hour window for us isn't like any kind of challenge where I am.
Yeah, but you get into, and I mean, I grew up in New England, and so everything is close by. But when I started working in the western half of the state, even with helicopters, things are still, by the time you go from on scene to whatever to hospital to the next motion, you can be looking at a lot of people that are outside of 3 hours with everybody doing the best they can with the resources they have. And we certainly have run across that. So I'd say we're on board with the 2 to 5 grams, probably closer to 3 of TXA under 3 hours if we're going to go to a massive transfusion protocol. But we probably, if we get in a situation like that, we're probably this person's been out there for 4 hours. And I'm not sure that those people being as hypotensive is quite as bad as the people who get that way in 10 minutes.
Yeah, if you're still alive 4 hours later, it's a good start.
You're kind of your own bioassay, in a way.
But I think that's also where TEG comes
Sure.
in, though, right? Because TEG can guide you towards TXA. So if it's been four
Right.
hours, they clearly don't need it right that second. What's another 15, 20 minutes after 4 hours
Right.
already? I think you can use it for that.
Well, I mean, to sort of switch a little bit, but continue in the same vein, we had another chapter in your issue that's teaching before, during, and after resuscitation, written by my very dear friend PJ Schnartz and Dr. Scarborough, Abraham, and Philip. And PJ and I go back almost 40 years, so a long, long time. As a matter of fact, I was just talking with him on the phone last night. But PJ and I, we trained together. We were in the Army together. We've spent a lot of time working on projects together. He'll be succeeding me eventually as the consulting editor for this series, which is coming up in the end of this calendar year. But let's talk a little bit about, all these things we've been talking about, things what to do, and here's the data. The next question is how do you get that into people's mindset and into their, and PJ talks a lot about the biology of learning, the neuroadaptive bits, the effects of stress and timing. And we could spend literally 6 hours on this. I won't make you do it. But what are your thoughts on sort of the biology of learning and the cognitive overload?
So my aside before I start, PJ's the reason that I guest edited this book too. So shout out to PJ. And I know PJ through the education world, through the APDS and surgical education and stuff. So this chapter, of course, is near and dear to my heart. Also, it's all about teaching. And he does talk a lot about the biology. I won't talk a ton about the biology, but I will talk a little bit about stress levels and cognitive overload because I think that's the most important. And there's a lot of good data that there's like a happy place for stress in terms of maximizing learning ability, right? Too little stress, people are not engaged enough and they just don't care. And so they don't pay attention and don't learn. And too much stress, they're solely focused on their stress level and it's fight or flight. And then they can't take anything new in and absorb it. And so it's we can't necessarily control, although we can to a degree, the stress level like in the trauma bay when we're actively running a trauma. Now, I do think sometimes as attending, some of our role is to make sure that the feel of the trauma bay is calm so that the residents can like do their thing and do what they need to do. But sometimes we can't. And if we can't, then the the post-trauma action reports end up counting a lot. The debriefs talking about what went well, what didn't, video review if you have that possibility. If you have time to talk about those things while the trauma is ongoing and make corrections, that's amazing. But in some patients, we just don't have that ability.
I found in a lot of the settings that I've taught people trauma, whether it's here in the States or overseas, that the first thing I have to teach the people who are ramping up to be the leaders is how to manage crowd control and how to manage communication things. I find that, there's cognitive overload because the situation's really complicated. That's probably been less common in my experience. And then there's cognitive overload because there are too many people rushing in, trying to do too many things at once independently, and the team is out of control and people are talking over one another. And especially, like even when I was in Iraq and Afghanistan, we had a rule that nobody talks louder than a conversational tone.
Mm.
Because if you just keep people talking normally and nobody's trying to escalate, then people feel calmer.
Mm-hmm.
Whether they are or not, I don't know. And we had, I think, as bad injuries as you're going to encounter in that environment. I mean, these people that come in with only one limb left and 1,000 entry wounds. I mean, that's pretty much sick as you get from trauma. But everybody sort of, but also everybody worked together every day. The team knew sort of reflexively each other's position. Teaching back in the States, there's always factors that are moving. You got different ER residents today. You've got different surgery residents today. You've got different ER attendings, some of whom want to get involved, some of whom don't, some of whom want you out of their way. I don't know if that's ever happened to you, but it's happened to me.
Yeah, you have a rule, you should always take your own pulse before the patient's and your heart rate should be lower than the patient's. And if it's not, you have a problem, right? The constant changing is like a real issue, especially with, and I'm sure it's not just where I am, but there's nursing shortages and turnover and a lot of travelers. And so there could be new faces every month and people we don't know. And that definitely makes things more challenging for sure.
I think one thing the military had going for it, and it is not an advertisement for the military by any stretch, But when they sent out, especially smaller units like forward surgical teams or shock resuscitation platoons, um, they've usually got about 15 or 20 people that train intensely together before they go over. And they've sort of rehearsed the moves, the gear, the equipment, and then they work together for usually whatever period of time they're over there. I mean, you may have some people rotate in or out for illness or the usual things that happen in regular life, but it's not like when I was a program director or director of medical education where every 30 days, all the resident people are going to change somewhat. And as you say, the nursing part, especially since the pandemic, is completely unhinged from turnover rates, and not because of the nurses, just the staffing issues.
Mhm.
People are moving around left, right, and sideways. Um, so I think it's way harder to get like you can't get a 9 month sustained trauma crew in a modern day trauma teaching environment.
So I think you just have to use as many adjuncts as you possibly can, right? Whether it's and lots of places do this differently, right? Even whether it's boxes on the floor where each person's role is supposed to stand around the stretcher, whether it's on the wall, there's like diagrams of where each person should be in their role. We just got, and I love them, we just got stickers for each role in our trauma bay. So I just walk in and there's one that says trauma attending, and I like slap it on my hat or my gown or wherever. And we have the recording nurse and then, airway, blah, blah. And this is really helpful. If you don't have a sticker, you don't belong in the room, right? So like, I think that really helps for crowd control also, because there's a limited number of stickers.
We did something very similar. We kind of stole it from the guys that worked aircraft carriers. We were working with some Navy guys, and they've got different colors. It's easy to identify who everybody is based on their things. So our stickers were color coded, so you knew who was airway, who was this, who was that. And you're right, if you didn't have one, you didn't come into the room without being asked. And the only people that really came in were like X-ray would come in, or
Mhm.
somebody to hand you a cooler full of this or that. But that made a huge difference when we were doing that, just to identify who's who. And particularly, I presume you guys work closely with your ER colleagues in these, or do you not?
Yes and no, actually. So we don't have an ER residency where I am. And so level 1, our highest activation traumas are owned by us. The only time the ER is actually involved at all is if the attending is stuck in the OR in something. The ER attending will like get things started until our trauma attending gets down there. But otherwise, they own the level 2 and 3 traumas, and then they call us for consults if they need us later. But in terms of our big trauma activations, it is all us, which is a good thing.
That is good. And in places where I've worked where we have had emergency medicine residencies, we certainly have come up with, for lack of a better term, sharing systems that allow people to get in. And I found, especially in those things where not everybody knew each other personally or by a line of sight, the sticker system was imperative. You've got trainees in there who aren't yours. Because these are people that I see every morning before we go to the OR at our morning conferences. They're like total strangers. But no, that's great. I'm glad you did. Where do you stand with incorporating simulation into getting your people up to speed?
We do a ton. And we try speaking a little bit about nursing turnover and stuff. We do big trauma sims, either probably averages to every other month. We have like a 2-hour block of time, and we time some of them with nursing orientation. So like the new nurses coming in, we use it as a way to make sure they're introduced to the trauma team, our residents, some of our attendings, the people they're going to be working with. Um, I think simulation, you get out of it what you put into it, right? You don't need high fidelity sims for it to be good, but you need to really try and put in the effort for it to be good. So you get out what you put in. But I think the biggest, learning opportunity in simulation is the team dynamics.
Right.
For sure. I mean, yes, you can also learn some of the rest of it, but the ABCs or putting in a chest tube or, that kind of deciding when to take a patient to the OR, you don't need a multidisciplinary sim for that.
Yep.
Although you can learn it there too. But you do need it for people to understand roles and how things are supposed to work.
No, I think you're right. And I think having people understand to me, when we did a lot of simulation, which we don't do in my current place because we don't have that level of training, but you need to know what the goal of the simulation exercise is. Whoever's in charge of it needs to at least know that. And then afterwards, you have to be able to sit down and calmly, hopefully, no reason not to be calm about a simulation, but go over with people, okay, here are the goals, here were the concerns, here are the benchmarks we wanted to hit, here are the ones we hit, here are the ones we missed. Let's look at what were the stumbling blocks on the ones we missed and give people credit for the ones they hit. And I mean, there are better and worse ways to give feedback. I've been on the receiving end of all kinds, and as most people have. But I think that if you, as you say, just the simulation itself, without really taking a step back when the event's over and cementing the learning efforts of it is not as useful. But and for that, I mean, you're a high-end program director, so I'm sure you focus a lot on the andragogy of modern education, as we all do, and try
It's a
to.
great word. And yes, we do.
Well, yeah, I mean, I trained in the days of immersion.
I said, see one, do one, teach one, right? That's how it worked.
Actually, it was never go home. It was be on call every other night for the first 3 years and then be on call every night for the rest of your life. That was the model we used. And there was no structure. And you got in it and you got grilled and awful sayings. And I'm not advocating for this in the least, but it was like residents were like Persian rugs. They should be walked on daily and beaten once a month. That was the kind of advice we were given for educational thought. And clearly, that's not the way to do it. But the one advantage of immersion was you didn't have any cognitive distractions because you had nothing to think about except for what you were doing, and then maybe sleep once in a while, which wasn't necessarily a brilliant training paradigm. But the fact of the matter is, it actually worked. I mean, it brought us the evolution of gastric surgery. It brought us the evolution of cardiac surgery. It brought us brain surgery. It brought us ICU care. I mean, my mentors and like Stan Dudrick invents TPN, and the guys that work with DeBakey and Cooley were the ones training us to do heart stuff. I mean, these guys, nobody thought about how they were being taught. They just had to learn it. And you could do it. Whether that makes better people or not, no, probably doesn't. But there is something to be said for living in it all the time and constantly reflecting on whether what you're doing is working or not. And we lost a little bit of that with the hours change, and we gained some other things back.
We could go on a full-on tangent about surgical education for sure, and it's something I could talk about for eternity. And I trained as the hours were changing. So my training time was we had two schedules, the one that we sent to the ACGME and the one that we actually followed, that like weren't exactly the same schedules.
I'm just going to not comment on that, but you go on.
That's how we did it for sure. But I think it's hard. Like, not only do we have hours restrictions, and I understand the reasons they came about, and I'm not saying they're not good reasons, but then we've also piled more and more and more non-patient care and clinical requirements onto residency also. So we've like truncated hours somewhat and added all kinds of other stuff.
Yeah.
And that gets really hard. You got to get real creative. That's why simulation, I think, has taken off too, because you have to get creative with how you're going to teach people things.
And I honestly think if you can't teach somebody this game in 80 hours a week, you shouldn't be teaching this game. Now, the problem is which 80 hours you're going to pick. I mean, because That's 80 out of 168. So you can't necessarily stack everything you want in the right order, but it really can be done. Um, my biggest complaint with the work hour stuff, and we are a little tangential, was that I thought they should have put the work hours restrictions on the staff people as well.
My thought, if we're going to give thoughts about work hours and stuff, is that I think they should be more prescriptive in the junior years and more flexible in the senior years, because there are no such thing as work hours, as you know, and I know, when you are done. And so I think we do people a disservice by creating this fake environment for them and then say, go forth into the real world. And I am convinced that's part of the reason that burnout is so high, is because we don't give people a realistic view of what life's going to be like when they're done. And I think some flexibility in the senior years to decide, this is a case I really want to stay for. I know that I'm post call, but that's going to be my life when I'm done. Like, ugh, the ACGME is going to like come smite me at the end of this podcast. John, editing.
I am thankfully Professor Emeritus, and so ACGME doesn't hold any sway over me anymore.
I have a little ways to go here.
Oh, that's okay. It's look, I be glad of it. Don't wish
Yeah.
your time away. But no, I think you're right though. But I think that flexibility is out there. But I think that the arguments writ large, that the whole system, I mean, we wouldn't tolerate it from pilots, we wouldn't tolerate it from a bunch of other people. Um, it's really driven by economics more than anything. And there are ways to work around it. And in my role later in life of spending more time controlling the destinies of staff people, especially their contracts, I thought that was an important thing to factor in, that they're a resource. And if they burn out, I mean, the two most expensive things you can do are recruit and retain. So if you're recruited people you like, you got to find a way to retain them. But anyway, we're slightly off topic, but as you say, we could probably go forever. But let's talk a little bit about minimally invasive surgery, and I even think that term now has lost its punch, for trauma, uh, Justania, and I may be pronouncing that wrong, I hope not, and Grushka. So basically, in this, I'd say for the most part, we're containing our comments to transcavitary approaches with videoscopic equipment. Let's just say belly and chest. We're not necessarily looking at endoscopy in the classic sense.
I felt really strongly about including a chapter like this because I do think that it's still controversial, even though it's 2024, and I think that's worthwhile to talk about. Um, Also, shout out to the authors who are from Canada, because we had two chapters written by um, Canadian authors, because we really tried to make this like surgical clinics of North America in its entirety.
But nice, thanks for reaching out to our Canadian friends, eh?
So yeah, they did a great job kind of summarizing what we can and maybe should use laparoscopy for. You know, and I think there have been some advances in the use of laparoscopy in trauma over time. Um, Initially, it was never, right? It's just like, don't use it. It's not appropriate when laparoscopy was coming about. Then it seems like it was diagnostic only. You'd put a camera in if you saw violation of the peritoneum in any way, you automatically opened. That was my training years, is what we did. Put a camera in, it was purely just to see if the peritoneum was violated, and then you opened. And these days you can do a lot more with it, you know, acutely and subacutely. And it has a larger role subacutely than acutely. But you know, without like hemodynamic instability or horrible traumatic brain injuries, there's kind of no reason to not start with laparoscopy. You can always make bigger incisions if you need to afterwards, but it'll help get a kind of the lay of the land. There might be things that are just easy to fix minimally invasively. There's increasing data that the miss rate for injuries is extremely low, although I think it was, you know, it was pretty high early on before people were comfortable with laparoscopy as a modality. What the authors don't go into in any way, and we do talk, this is titled Minimally Invasive Surgery. They don't really talk about robotics at all, and I feel like robotic surgery and trauma, people will cringe a little bit, but I think there's going to be a role and it's going to grow over time too, as people get more and more facile with the robot, because I think that there are some things that are easier to repair robotic than laparoscopic and can avoid opening.
Well, I think you're right on all that. And having predated, I actually predate CT.
You're dating yourself, Ron.
I can't help it. It's just a fact. It's the calendar is, but we got our first CT scanner in my fourth year of medical school, which was a Philips MX8000 single slice scanner. It is the same exact scanner that Uncle Sam gave me to take care of Mosul in 2006. So it was 45 minutes to scan a belly and an hour to do a head. So in terms of practicality, but it brings up, I mean, so to me, like, and being around before laparoscopy, and I was on the ground floor of that, and I love laparoscopic stuff. And robotics is to me computer assisted videoscopy. You get a lot more degrees of freedom with things, but it's sort of like eating utensils. If somebody brings you a bowl of soup, you should reach for a spoon. If somebody brings you a steak, you might want to get a fork and a steak knife. I mean, there's slightly different tools for slightly different things. And as you allude to, or at least I think you are, I'm not trying to put words in your mouth, but the decision path depends upon a number of things, not the least of which is how much time do you have and what question are you really trying to answer? Because some questions you don't need to poke a hole in anybody to answer. You get a high quality CT or a high quality MR or ultrasound, and you've got your answer. And other people, not so much. And now CT is like super fast by comparison. And in a lot of busy places, it's right in the ER, so you can practically scan them on the way to putting a tube in their airway. Not really, for all you ATLS fans out there, but you can get information that's high quality much more quickly. And I think you have to look at a number of factors, like what's going on with the patient first and foremost. The second bit, I think, is what's your own skill level? Do you have the team at the right time? Have you just run out of laparoscopic gear? I mean, that happened a couple weekends ago. We were down to like our last scope because we had an enormous run on people that came in that we operated on, and our central sterile people weren't around for some reason. It was a weekend. They're probably smart. They took the weekend off. But you do have to look at that. And I think there are going to be people who are highly capable with videoscopic approaches to where their miss rates are going to be very, very low, and their solution rates, for lack of a better term, I don't know what I should call it, something better than that, but their ability to achieve a definitive solution videoscopically will be fairly high. And that matrix is going to be very different from surgeon to surgeon and team to team and facility to facility. I know in the literature they cited, accuracy rates of 50 to 100%. I could not support a 50% accuracy rate for go, no go on a laparotomy. If you're concerned enough to put a hole in somebody that's small, you better be comfortable enough that when you take the scope out and stop, that you're done, unless there's some other reason. To me, the robotic piece that's always been problematic is the time. Docking time, setup time. Not everybody has docking compatible OR tables. And I found even for non-traumatic work, if you've got a procedure that requires a lot of repositioning the patient to get gravity on your side, you got to have the right docking table or the robot really hinders you. I mean, those are all things that are fixed with engineering. But do you use a robot much in your trauma work?
So I use a robot a lot in my general surgery stuff, just for fun. So I like to think that I'm pretty robotic facile. I use the robot never for acute trauma, for a lot of reasons. Um, Partly because those patients tend to always come in like nights, weekends, whatever, and our hospital's not equipped to use the robot on off hours, no matter what. But I will use it for delayed reasons, right? So if I have a patient with a spleen that we did non-op, but like 3-4 days later, they're still complaining of like horrible abdominal pain, and that it's like just peritonitis from all the blood and they need a washout or something. I might use it for that if I think that I could potentially have to take the spleen out also. If I'm literally just going to suck blood out, there's no point in the robot, you know. I fixed a delayed traumatic diaphragmatic hernia with it once. That was cool. Patient went home on post-op day 1. It was like a great case. His was delayed. He was not a penetrating mechanism of injury. He was a car accident and just broke his entire left side
Blunt trauma. Did you fix it through the belly or through the chest?
through the belly. Yeah, fixed it. And he came in vomiting and his stomach was just like, it looked like an hourglass. It was just like incarcerated right up there. Like that was a great use of the robot. You asked me to do that laparoscopically, I'd probably still be in there like 4 years later. I am not a laparoscopic connoisseur in any way.
I did the first lap. I had the same exact story you had. It was a trauma surgeon driving through Portland, Maine, who like went into a bridge abutment and came in with a ruptured left hemi diaphragm. And he was a friend of ours, and they call us, and we went in, and we had just started doing laparoscopy. This is like 1990, something like that. And we fixed his diaphragm. The guy later presented himself at a trauma conference, and everybody was totally critical. He didn't say any of the details about what was going on. The whole audience like was throwing tomatoes, about how this never should have been fixed. And so the guy lifts up his shirt and he says, "Here's my scars." And those two guys in the back who are cowering were my surgeons. So, I mean, you can do it. I've certainly had friends. I think most of my thoracic friends who really love robots would tackle it from a chest approach. But no, good for you.
I think I think one of the important points that we're kind of talking around, but that you bring up with those comments too, is that like challenging dogma does become necessary. Technology changes, right? What's the average? It takes like 17 years or something is the average amount of time it takes to incorporate like convincing evidence, which is like nationally, which is crazy town. It's like it's a ridiculous number and amount of time. And so we get very fixated on what we should and shouldn't do and then like to throw tomatoes at people who push the envelope, but it's the only way progress is made.
That's true. And sometimes we make progress and we have to walk it back. I mean, but you're right. I mean, one could argue that if we suspended the entire R&D budget for medicine for 5 years and just taught people what we already knew, we might get more bang for our buck. But I don't want to suspend. I don't want people to think I'm a Luddite. We don't want to advocate suspending R&D. But we're running a little short on time. But let's just dive into the nutrition one a little bit. So, Nutrition for the Critically Ill Trauma Patients by Williams and Ye. So, I mean, I think the first thing is that they address, and I'm curious your thought on. I've always found it very hard to look at nutrition as an isolated variable that you can really independently assess whether it's making people better or worse, because there's usually so many other things going on. And historically, there's so much variation on the other skill sets we have. So what do you think?
I don't think you're wrong. I love the idea that we like could use nutrition as a targeted therapy. Like I love the idea that we could. It hasn't like fully borne out in the literature. Obviously, we used to use, really specific formulas like Oxypa for ARDS because we thought that would like fix the lungs. And we really just think that glutamine is going to fix all things small bowel. And none of it's actually, I want it all to work so badly. But I think we do know that especially people that have high nutritional needs, whether they're trauma burn patients, whatever, we need to feed them in some way. And we're bad at doing that, for a variety of reasons. It's
Sure.
not that we don't want to. Sometimes it's intolerance. Sometimes, and dogma has stated that TPN is the devil for a really long time. And I am fully on the TPN is the devil like train. But the authors in here do make a lot of good points that TPN maybe used to be the devil, but it wasn't because of the TPN. It's because of poor line care and a bunch of other stuff, and maybe we can use it in specific situations. And so again, I think we just need to be flexible and facile and see what data shows us and change with it. But I think not feeding people is bad. feeding people is good, and the more, not like the more volume, but the sooner and the more complete their nutrition can be, the better off. It's a little bit like whole blood, not to like come full circle, right? But we want to like mimic their normal diet when they were healthy, just like we want to mimic what people are losing when they bleed. And we miss the mark so often.
I could not agree with you more. I mean, and I think you make the absolute point that if anybody who's listening to this podcast gets one thing out of this entire discussion, we spent decades getting away from normal when people got hurt, and we more often than not made it worse. And what we've learned over time is get it back to as close as normal as quickly as you can, but not quicker than you should.
Mhm.
And certainly, I do think there needs to be a huge divergence of opinion on TPN versus enteral nutrition, because if you can use the gut, you have a much higher burden to explain why you're not doing it. There's far fewer intermediate pieces that can go sideways. If you need TPN, you should use TPN. But as you say, not everybody has the systems in place because there's just a lot more pieces in the error chain that can lead up to problems. And we also have a pretty highly variable population in terms of their pre-injury or pre-traumatic nutritional status and what their own reserves are.
And we don't have great, like at all, ways of figuring that out. You can't do BMI because a lot of people who are overweight are still nutritionally deficient. So that doesn't help. And you can't really ask them generally.
No, but like when you're dealing with the military folks, they're almost all elite athlete status. You know that before they got shot, they had a ton of muscle mass, they had a ton of reserve, and they had a ton of physiologic. Now, that doesn't translate well into the general civilian sector,
No.
not even close, but like where I am now, I deal with a lot of college athletes that get sick. These guys, mostly guys, they're big, but some of the females too, they're going to take a hit for a while,
Yes.
nutritionally, whereas the 80-year-old who comes in with septic shock from perforated diverticulitis and already has a bad heart and marginal lungs, they're not going to take a hit for much at all. But I think it goes back to what's your pretest probability? What's your problem and how are you going to solve it?
Hmm.
And to your point, people need to think it through because there is no one right answer. And maybe we'd be better at getting rid of dogma if we just agree that the answers are going to change, but the questions need to be refined. I
Yeah.
don't know. Maybe. What are your thoughts on? So what do you use for a cutoff for TPN?
Again, I am team enteral nutrition for sure. Anybody who's ever worked with me knows that. And I think there's a ton of reasons physiologic to do that. 5 to 7 days is my cutoff for TPN. Um, we have been using it earlier these days if we know that patients, like there's no way they're going to be able to be fed within that time frame.
Do you have calorimetry or metabolic carts, or are you swinging from the fences?
So almost nobody has that, but in the state of Maryland, we have trauma grants, and we decided to see if we could use it this year for indirect calorimetry, and it went through and got approved. So it's not here yet, but it's coming, and I am very excited about that.
When PJ and I were in Portland, we used them on everybody. And
So great.
that would have been the early, like late 80s, early 90s. And we just had ICU folk that were into it. And we got a couple of carts and we were doing indirect calorimetry on everybody. We were still using Swan, so we weren't totally brilliant. Don't get me wrong. I mean, we were out
I love
They're
swans, and
great.
I think the reason that the data shows that they're not effective is because people don't know what to do with the numbers. I feel strongly about that.
And I'm with you. Um, I will say that you can get by without them because I've lived both lives, but an oximetric swan was like a magic wand. You could figure out everything if you knew how to do the
But you
formulas.
had to know the numbers. And if you didn't, no kidding that they didn't work very well.
That's right.
We digress
Most people
again.
challenge, we do. But yeah, understanding thermodynamics and understanding basic physiology goes a long way. In terms of trophic feeding, sort of what are your thoughts on first of all, what do you think trophic feeding is? Because I think there's about a bunch of different definitions of that.
I have a number. I think it kind of depends on the size of my patient, but I'm a 10 or 20 cc an hour person and leave it at that. That's what I do for trophic feeding. I do believe in it. I feed people on pressors as long as they're not super high or rapidly escalating. I feed people with open bellies.
Use elemental stuff, non-elemental stuff?
Sometimes. I don't think you have to. I don't always start with elemental, but if there's any evidence of intolerance, we'll switch. Yeah, I am an early and often feeder, and I don't think it's covered in this chapter, but the current, Brain Trauma Foundation guidelines, at least, there's so many things that can't be recommended because of lack of data on their guidelines, but one thing they do have an actual guideline for is that nutrition should be at goal within 5 days of injury, and there's a mortality benefit to that. And it's one of the only things that actually has mortality benefit in head injuries.
Since we're kind of running low on time, I mean, first of all, again, thank you and everybody who contributed to this for giving us a ton of stuff to work with. And I think the people who read this and take it to heart will do better with their program directors and better on their boards than if they do not. So we encourage it. And for those who already got their boards, you still need to know this stuff anyways. Life moves on. So try to keep up, and you've helped me to keep up, and I do appreciate it. Are there any other thoughts from the issue or these chapters that you think we didn't cover that you'd like to, or?
No, just a huge thank you to all the authors who put the work in. I think it was a great edition that was pretty comprehensive, hit things that aren't always talked about, and yeah, I'm proud of it. So I think it's great.
Okay. Well, we really appreciate everything that you did and everybody else did, and the whole clinics community owes you a big debt of thanks.
Thank you for joining us for this Surgical Clinics podcast devoted to trauma across the continuum. The 4 articles discussed, as well as 11 others, are in the April 2024 issue, Volume 104, Number 2. The series is available for individual print or online subscriptions. Visit www.surgical.theclinics.com to subscribe. The series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on X/Twitter @Surgical Clinics, and you can find our podcast on most major audio streaming platforms, including Apple and YouTube. Visit www.theclinics.com for more details. Thanks for listening.